Well, here we are back with chapter 45 and part number 4 of Geriatric Emergencies. We're going to pick up here with talking about some renal conditions as they relate to geriatric patients. And then we'll get into some endocrine issues and then round it off with, I can't remember which one it is now, some toxicology stuff. So let's go ahead and get started. So when it comes to renal conditions, UTIs are the most common thing that we see in older adults, and they're also most common in older adults. They usually start in the lower urinary tract where normal bacteria kind of grows in the urethra. Women, of course, are more prone to this because they have that shorter urethra. And men after the age of 50 are at much higher risk of UTIs due to some prostate-related urethral obstruction kind of issues. Common risk factors, of course, are going to be things like, that kind of coincide with some other stuff. Of course, diabetes, prostatitis, inflammation of the prostate is going to increase the risk of a urinary tract infection. Then you have cystocele, urocystocele, kidney obstructions, and indwelling urinary catheters are always increase the risk of the development of urinary tract infections. Typical presentation of patients with a UTI are going to be a fever, maybe shortness of breath. They may even have some GI symptoms. Neurological symptoms are not at all unusual with a UTI, and they'll have poor urinary output, increased frequency. They maybe even have some blood in there and maybe even feel some pain, frequent urges to urinate and difficulty urinating. Many elderly patients developing a urinary tract infection sometimes is a prequel to sepsis or some more serious things that kind of happen. So as patients age, it becomes more and more difficult to be able to get these infections under control. So urinary tract infection can be quite serious if not managed and taken care of quickly. If they have an indwelling catheter, look for any sediment in the Foley. Look at the color of it, the opacity of it. So is it clear? Can you see through it? Does it have blood? Is it, has a dark color to it? Is it a yellowish color or a brownish color? Or, any of those things in there. Anything out of the ordinary, so you can tell whether the urine's concentrated or whether it's very clear. That kind of stuff is going to be important to kind of give you a bit of a window of how the urinary tract is functioning. Some later signs and symptoms we might see, of course, would be hypotension once that develops into full-on sepsis, and tachycardia, diaphoresis, and of course pale skin and those kinds of things that we would normally expect to see with patients that have kind of went down the sepsis pathway. I can't overstress the fact that urinary tract infections can easily spread to sepsis. They can spread to kidney infections, and they can spread throughout the body. So that's why it's important that they're dealt with and not just kind of overlooked. But most of the time, by the time you get a call for those, they've progressed to a pretty significant state. Renal failure involves the sudden drop in glomerular filtration rate, causing toxins to build up in the blood. It occurs when the kidneys can no longer effectively excrete the waste that they once could or that they need to. The kidneys eventually lose their ability to create concentrated urine, and the kidneys can no longer regulate electrolytes, pH balance, and even blood pressure. So things are starting to go south quickly. Risk factors are going to include, top of the list, always with a lot of the risk factors that we've been talking about, diabetes. And of course, a cardiac history, and that cardiac history is going to be related more to hypertension. Uncontrolled hypertension causes significant damage to the glomerulus within the kidneys, as does diabetes. Polynephritis can lead to damage of the kidneys as well, as can autoimmune disorders and polypharmacy, being on multiple medications and those kinds of things. These Renal failure may actually require some lifelong hemodialysis treatments or even a kidney transplant. If a hemodialysis treatment is missed, it can become a severe advanced life support emergency because of all the buildup of the toxins and the poor regulation of the electrolytes in the body that the kidneys normally do. Some symptoms we're going to typically see with someone in renal failure is they may initially present with hypertension, headache, anxiety, fatigue, anorexia if they've been dealing with this for quite some time, vomiting, increased dark or even absent urination, altered mental status, and maybe even progress to the point of seizures because of the buildup of toxins and electrolytes. So what we want to do with these patients, because of the electrolyte and toxin risk, we want to make sure that we put them on we get a 12 lead EKG to help kind of identify any imbalances that may be present and really know what we're up against cardiovascular wise. Monitor all vital signs. But remember, if they have a fistula for dialysis, then we don't want to take a blood pressure in the side that has the fistula. Take it in the opposite side, and you may even have to revert to taking it in the leg instead. Continuously monitor the end-tidal CO2. Assess breath and bowel sounds pretty regularly. And of course, you want to transport the patient to a facility that's going to offer inpatient hemodialysis. There's not a lot of those in the more rural settings, so it's going to be a more metropolitan, a larger city kind of setting that's going to offer something like that as an inpatient basis. Administer fluids as needed, but be careful about fluid overload. Treat dysrhythmias according to ACLS guidelines. Monitor that urine output. If there's a urinary catheter in place, you'll be able to get some measurements on it. And of course, make sure you document all the fluids that you give them, all the fluids that you administer, and pass that along to the hospital. Incontinence, bowel and bladder control depend on the automatically correct GI and GU tracts, anatomically correct, sorry. So it requires that those tracts be anatomically correct for everything to work properly. Intact and functioning sphincters are necessary to maintain continence. And of course, cognitive and physical functions must be worked properly to maintain continence. Urinary continence often affects people both socially and emotionally. Many individuals do not admit to having an incontinence issue. Even fewer people seek help for their incontinence issue. Incontinence can also cause skin irritations, and prolonged incontinence may lead to a complete skin breakdown. And this also increases the risk of urinary tract infections. As people age, bladder capacity tends to decrease. The muscles that control the sphincters, the strength of those begin to weaken with age. Pressure on the urinary sphincter usually signals the need to urinate, and older adults may not recognize when their bladder is full, leading to involuntary contractions. Nighttime incontinence can occur because older adults may not wake up when they need to urinate, and some adults know they need to urinate but may not be able to reach the bathroom in time. There are two major types of incontinence. There's stress incontinence that happens during activities like coughing, laughing, sneezing, lifting, or exercising. And then there's urge incontinence that is triggered by things like hot or cold fluids, running water, and even thinking about going to the bathroom. We've all probably been there. Always be discreet and not judgmental when caring for patients with incontinence. If time allows, assist the patients with gathering their supplies that they need to help manage their incontinence before transporting. If the patient loses bladder control, keep them covered until you can help them change their clothes. During long transports, try to minimize the time the patient remains in urine-soaked clothing so we can help to avoid skin irritations and skin breakdowns. Urinary retention or difficulty urinating is the opposite of incontinence, and it can usually result from various medical conditions. In men, benign prostatic Benign prostate enlargement puts pressure on the urethra, making urination difficult and causing frequent urination. BPH may cause disrupted sleep due to frequent urges to urinate with little actual output. Bladder and urinary tract infections can cause inflammation that leads to urinary retention. And pain from infection may cause patients to completely avoid trying to urinate. Urinary retention can occur after the placement or removal of a catheter. Loss of bladder wall elasticity can lead to small amounts of retained urine, increasing the risk of UTIs. Temporary urine retention may lead to pain, abdominal distension, or acute or chronic renal failure. All right, so let's look at some endocrine emergencies. So when we're dealing with endocrine emergencies, geriatric patients may actually present with diseases such as Graves' disease, which is a form of hypothyroidism, or Addison disease, which is Graves' disease is hyperthyroidism, Addison disease is hypoadrenalism, Cushing's syndrome is hyperadrenalism, or maybe even osteoporosis or diabetes. These can all be endocrine connected or endocrine related issues. One in every 4 people over 65 has diabetes. Most of these cases are type 2 diabetes. Normal aging changes increase the risk of developing diabetes. Having multiple chronic diseases is the most common risk factor for someone developing type 2 diabetes, and a family history of genetics also can play a role in this. Of course, age, diet, obesity, sedentary lifestyle also add to the risk. Managing diabetes becomes more complex when with other illnesses, especially when infections and things like those become present. Older adults often have multiple health conditions that make diabetes management more challenging. And remember, if you'll think back to many of the risk factors for the diseases that we've talked about up to this point, or the illnesses that we've talked about at this point, number one on that list of many of those was diabetes. If a patient can manage their diabetes, they're going to greatly reduce the risk factors for other issues as well. But as you can see, it's not always easy to do. Diabetes can cause 2 life-threatening conditions, of course, and we've talked about these previously. Hypoglycemia, which occurs when the blood glucose drops below 45, and hyperglycemia, when the blood glucose rises above the normal range of 60 to 120. Remember, though, that geriatric patients may, in fact, have a higher than normal baseline glucose level. Older adults have a much higher risk for hypoglycemia. This risk increases due to confusion about medication doses and even how to use them. Inadequate or irregular eating habits also contribute. They may be compliant on their medications, but they're not eating enough food to kind of counteract the medications they're taking. Cognitive issues may prevent them from recognizing some of the warning signs related to hypoglycemia. The warning signs of hypoglycemia may also be less noticeable in older patients as well. So they're kind of masked by some of the other things that go on. Delirium can sometimes be the only sign of hypoglycemia in older adults. Other symptoms include mental status changes, confusion, and maybe even sweating. Hypoglycemia may cause a decreased respiratory effort, and new onset diabetes often shows no symptoms in older patients. Risk factors for hypoglycemic hyperosmolar non-ketonic syndrome, or HHNS, include infection, which is the most common cause. Other risk factors are hypothermia, hyperthermia, cardiac disease, pancreatitis, and stroke. HHNS may present with blood glucose levels over 600. Symptoms often include acute confusion and dehydration. The key here is, with anything diabetic related or any altered mental status, is making sure that we get those baseline glucose levels so we have a better idea of what we may be dealing with. Hyperglycemia and hyperosmolarity cause osmotic diuresis and shift fluid in the blood vessels. This can lead to dizziness, confusion, and altered mental status and excessive thirst. Pre-hospital treatment is similar to that of younger patients, but requires a more cautious approach to fluid resuscitation, so we don't worry about putting a patient in a fluid overload status. Assessing blood sugar is harder in older adults due to age-related changes. Peripheral vascular changes make many older patients appear paler and cooler than usual, and skin changes may reduce sweating and making diaphoresis less noticeable. Baseline mental changes can be mistaken for sudden mental status shifts. Assess all vital signs every 15 minutes with our diabetic patients. Get a 12 lead and continuously monitor end-tidal CO2 as well as ventilatory status with capnography. Treatment follows the same guidelines for that of other patients, but extra care with fluid resuscitation and maintaining electrolyte and balance should be taken with these patients. Of course, a lot of talk to this point has been about, diabetes and its impact on other diseases and illnesses. So preventing type 2 diabetes is going to involve lifestyle changes like diet restrictions, regular exercise, and getting weight under control. Long-term management is going to include limiting carbohydrate intake, and the patients may actually need insulin or an oral anti-hyperglycemic medications. Preventing complications requires aggressive wound care, frequent kidney infection tests or kidney function tests, and managing neuropathy related pain. Thyroid disorders. Many older patients show no symptoms of having thyroid disease, but it is often found during routine blood tests. Adult hypothyroidism is also known as myxedema. This condition slows down the body's metabolism due to low or absent thyroid hormones. Signs and symptoms can resemble normal aging, such as cold intolerance, constipation, dry skin, weakness, and weight gain. Many older adults have had thyroid surgery and are often taking synthetic thyroid hormones. Acute hyperthyroidism or thyrotoxosis can present with less obvious symptoms, such as tachycardia, which is commonly seen in these patients. Older adults may show fewer tremors, less anxiety, and fewer hyperactive reflexes than younger people. Atrial fibrillation is more common in this group, and some patients may show weakness, lethargy, or even depression. Patients with hyperthyroidism or hypothyroidosis may need supplemental oxygen. Hypoglycemia in these patients might require treatment with D50, and hypothyroid patients often have reduced respiratory effort and may need positive pressure ventilation. A continued drop in hormone levels can lead to myxedema coma. Myxedema coma involves physiologic decompensation and is more common in women. It mainly occurs in the elderly population. All right, so let's talk about a few of these immunologic disorders. I think it's a pretty short section here, so there's not a lot to talk about. Infections can be severe and life-threatening, as we've talked about multiple times so far, and sepsis can develop when microorganisms or other toxins enter the bloodstream. Patients with sepsis may appear hot or flushed. They often have rapid heart rate and fast breathing. Other signs are going to include a temperature above 100 degrees or even below 96.8. The respiratory rate may exceed 20 breaths per minute, and the PaCO2 may be less than 32. The pulse rate is often 90 beats per minute, often over 90 beats per minute. Measuring lactate levels with these patients at the point of care device may be helpful in assessing whether or not you're dealing with a true sepsis emergency. In older adults, confusion, altered mental status may be the first sign of sepsis. They may not show a fever or typical vital sign changes that we see in younger patients. Okay? So, toxicologic emergencies, this is where we're going to finish out part 4. Older adults have a higher risk of adverse drug interactions or drug reactions and interactions. This increased risk is due to the slower drug metabolism and reduced liver function. Decreased kidney function lowers drug elimination, and changes in body composition affect how drugs are distributed in the body. The central nervous system's response to certain drugs may also change. Body changes can impact how medications are used. Declining vision, especially with small print and night vision, makes reading medicine labels much harder. This can lead to medication errors. Short-term memory loss may cause patients to accidentally take extra doses because they forget if they've already taken their medication or not. Polypharmacy, or using multiple medication, is very common in older adults. But the problems arise when medications interact or dosages aren't adjusted properly over time. Multiple chronic diseases lead to more medications and higher risk for adverse reactions. This can create a cycle where more medications are added to treat the side effects of medications they're currently taking. The risk of hospitalization rises with the number of medications taken, and the safest dose is the lowest one that can effectively treat the conditions. Some patients may not get their medication due to caregiver theft, which can happen at home or in care facilities. Suspect theft if a patient reports severe pain that matches their vital signs. Medication non-compliance often leads to worse health outcomes in older adults. Non-compliance includes failing to fill prescriptions. It also involves improper medication administration. Some patients stop taking medications against medical advice, especially if they have adverse reactions. Or taking the wrong medication is another form of medication non-compliance. Some patients take medications prescribed by different doctors who are unaware of the full regimen of medications that they're taking. Others use over-the-counter drugs or medications meant for someone else. Complex or changing drug regimens can make compliance much harder. Patients may struggle to remember changes in their medications, and they might not fully understand how to take their medications. Difficulty opening medication containers can also affect compliance. Aging-related changes in pharmacokinetics can cause toxic drug effects. Older adults are more prone to reactions due to the changes in body systems and composition. Increased body fat can extend a medication's half-life, and medications that affect the central nervous system commonly cause adverse reactions. Barbiturates, benzodiazepines are frequently linked to toxic effects in elderly patients. Dosages for central nervous system active drugs should often be reduced as the patients age. Reduced nervous system responses raises the risk of adverse anticholinergic effects, and most bronchial dilator medications work less effectively due to the decreased beta-adrenergic receptor sensitivity, which results in non-compliant reactions in the lungs. Diuretics and antihypertensive drugs may cause hypotension and orthostatic changes because of reduced cardiac output and lower total body water volume. Decreased glucose tolerance can lead to hyperglycemia for medications like diuretics and corticosteroids. Pharmacokinetics can be influenced by diet, smoking, alcohol use, and other drugs, even including over-the-counter medications. Drugs processed by the liver and kidneys may build up to toxic levels in older adults, and optimal doses for these drugs are not always well known. In general, doses should be reduced to avoid the risk of toxicity. Some drugs can cause toxic effects like psychiatric symptoms and cognitive impairment more often in older adults. These drugs are surprisingly common and include things like antibiotics, anticoagulants, digoxin, diuretics, and NSAID medications. Many older adults see multiple doctors for different health issues that may require pain management and sedation. Some states use a statewide system to monitor and control the distribution of scheduled medications through pharmacies. Substance misuse in older adults often happens in response to major life changes such as losing a spouse, declining health, or even low self-esteem. Alcohol and drug abuse in older adults can result from taking many prescribed medications. Aging causes decreased body mass and total body water volume, which raises blood alcohol levels. Changes in digestion, kidney, and liver function slow down alcohol elimination from the body as well. Recognizing substance abuse in older adults can be quite challenging. It may be hidden or even accepted by family and friends. Asking about substance abuse is an important part of the assessment because it can affect emergency assessment as well as their ultimate care. All right, so that is the end of part 4 of chapter 45. We got one more part to go and then we'll wrap up chapter 45. See you back in part 5.